Today's lecture is going to be on the wrist and the hand joints. So we'll start with the hand. One of the most interesting aspects is going to be the articulation. So when we're looking at the articulation, when we looked at the articulation of the elbow joint, the majority of the articulation was between the ulna and the humerus. And when we're looking at the articulation about the wrist joint, we're going to see that the majority of the articulation is going to come between the radius and the carpals of the wrist. So I've compartmentalized or divided up the bones of the hand. First, we see the radius, and then we see the carpal bones that will be a loose configuration, but they're bounded by a lot of ligamentous support. We have the metacarpals, and then the division between the metacarpals and the phalanges or the fingers. So when we're looking at the 8 carpal bones, we'll start at the most proximal row, so closest to the shoulder joint. The first one is going to be the biggest, which is going to be the scaphoid. That's located directly with the articulation of the radius. And then moving to the right, we have the lunate or the moon-shaped bone. And then moving one further towards the pinky finger or the fifth finger, we're going to see how it's in line with the triquetrum. And then on the dorsal surface, if we would turn our hand over on the triquetrum, we would have a small pea-sized shaped bone called pisiform. So on the distal row, again, we're looking at the metacarpals or bones of the hand. We see that this would be number 1 or the thumb, number 2 the index finger, 3 the middle, 4 the ring, and 5 the pinky. So starting closer, the one that articulates most often with the thumb is going to be the trapezium. The one that's mostly articulating with the index finger is going to be the trapezoid. The one that's articulating with the middle finger would be the capitate. And then finally, between the ring finger and the pinky finger, 4 and 5, we see the hamate or the hook-shaped bone. So one of the things that we're going to be looking at in this picture here, and I'll just draw a circle around, is going to be this kind of location between the thenar muscle, which is the muscle of the thumb, and the hyperthenar, which is on the pinky side. So this is a cross-sectional diameter. Again, this is your thenar, this would be your thumb, and then this would be the hypothenar. So we're in particularly looking at someone's right hand. So when we're talking about a carpal tunnel, most often the carpal tunnel is going to be, the cause and effect is going to be the flexor retinaculum. So when we're looking at the flexor retinaculum, and a retinaculum's importance is to hold all these tendons that are located here in their tract for contraction, for flexion of the fingers. So this retinaculum's job is to make sure that we compartmentalize this area. But a carpal tunnel is going to involve a couple of structures. One, the most often that gets irritated and it's closely related to the flexor retinaculum, is going to be the median nerve. And then we see the flexor digitorum profundus, which is going to articulate the interphalangeal joint, or flexor digitorum, yeah, and then this flexor digitorum superficialis is also going to articulate the phalangeal joint. And then the one that's not listed on here is the palmaris longus, which is one of these groupings of tendons that goes through. So when we're looking at carpal tunnel syndrome, it's in particularly with the overuse of the phalangeals, such as typing or any repetitive work. And what happens is this flexor retinaculum and even the palmar carpal tunnel carpal ligament will compress onto the median nerve. Once it compresses onto the median nerve, The first thing that happens is loss of sensation through the fingers, and then eventually loss of motor control. The surgery is very simple to fix. This location here is your thenar muscle, and this is your hyperthenar muscle. And they would make a surgical incision, just releasing this flexor retinaculum and the palmar carpal ligament. Releasing that or cutting that will allow or to decrease the pressure on the median nerve. The recovery rate for this is usually about anywhere from 1 to 2 weeks. So again, when I mentioned the wrist joint, we're looking at the carpals of the wrist. And you can see that the majority of the articulation with the carpals of the wrist is going to occur with the radius, and this is called a radial carpal joint. So these carpals are interlocked together, and they're bonded together through a series of small ligaments and this articular capsule. And we can see when we see this, it allows for flexion, extension, ab and adduction, and even circumduction. Another note, this interosseous membrane, which is a dense connective tissue, lies between the ulna and the radius, and this helps hold the position of the ulna and radius, the distance when we go into pronation and supination. And then from the carpals, we begin the transition. So this would be the carpometacarpal joint of the thumb, and this would be the carpometacarpal joints of the phalange, or with the phalanges. Mentioning earlier, when we see most of the wrist flexors and finger flexors, their origins are going to be more on the medial side. So we can see it more on the medial epicondyle here, or the condyloid ridge, or the coronoid process, but any of the structures that are located more on the medial side. For the lateral epicondyle, the lateral side, this is going to be the origins for many of the wrist extensors and finger extensors. So when we're looking at the wrist joint, we see that we have more ability to do wrist flexion. So we have the ability to do 90 degrees of wrist flexion versus extension of 85 degrees. And then when we look at ab versus adduction, I put the R here. This is referring to the radius. So when we go into radial deviation or abduction from a standing position, we can see that we only have 15 to 25 degrees, and it's usually related to the radial styloid process that's located on the distal portion of the radius. And then we have the ability on the ulnar side, we call it ulnar deviation, but you can see here that we have the ability to adduct or move closer to the midline 25 to 40 degrees. So one of the things about the phalanges that's really important is these collateral ligaments. These collateral ligaments, they form an X across the side, and they also form an X on the dorsal surface. These collateral ligaments, they allow for play in the phalangeal joint, so the ability to move each one of these joints. And then these collateral ligaments also allow for the tendons such as the flexor, digitorum superficialis, to run along that tract for articulation. When we're over here, we're looking particularly, I showed you earlier, the radial carpal joint, and then we have the carpals of the wrist. And right here, this is the carpometacarpal joint. So the connection of the thumb between the carpals of the wrist of the thumb and the phalangeal joint. And then in the fingers, we have the metacarpal phalangeal joint. The thumb has one also. In the fingers, we have the proximal interphalangeal joint. The thumb has one also. And then in the fingers, we have the distal interphalangeal joint, and you can see that it's missing in the thumb. So the thumb has the carpal metacarpal joint, the metacarpal phalangeal joint, and the interphalangeal joint, but it does not have the distal interphalangeal joint. So when we're looking at the fingers, what we see first is going to be the metacarpal phalangeal joint. So this is going to be the connection of the metacarpals of the hands and the phalanges of the fingers. So we can see here that we have a high degree of flexion, greater than 90 degrees up to 100 degrees. And then at this joint also, at this connection, we have the ability to go into extension roughly at 40 to 45 degrees. When we're looking at the proximal phalangeal joint, so moving further down, we're looking at this joint right here. We can see that the proximal interphalangeal joint can go into 90 to 100 degrees of flexion. So we're increasing the amount of flexion from the previous joint, and then it can also return to its neutral position. And then the distal interphalangeal joint, it has the ability to go into 90 degrees, but more importantly, it has the ability for a little bit of hyperextension for 10 degrees. This hyperextension plays a role with grasping objects with the phalanges or the fingers. So as previously mentioned, we have 3 joints in the thumb. The first one we'll talk about is the connection between the metacarpals of the hands and the phalangeals or the phalanges of the fingers. It has the ability to do full extension or full flexion from 40 to 90 degrees. This is what gives us the ability to do opposition. So at this joint, when we talk about opposition, is being able to bring the thumb to the tip of the pinky finger, and we can check for opposition or the ability for motor control function with that. This is a good cervical and brachial plexus test. And then the interphalangeal joint, as mentioned before, we do not have a distal phalangeal joint in the thumb, so the interphalangeal joint can roughly do about 90 degrees of flexion. Again, it plays a role in opposition. And then finally, the connection between the carpals and the metacarpals of the thumb. We see that this is where we do ab and adduction. So this illustration is a little bit difficult, but basically we're pulling the thumb down the palm side. So just dragging the thumb along the palm side. And this is what we consider to be AB or abduction. So these are all considered to be extrinsic muscles. We have a series of intrinsic muscles of the hand, but an extrinsic muscle, these 6 muscles move the wrist, but they're not really associated with the finger or the thumb. So primarily when we're looking at the extrinsic muscles of the wrist, these are going to originate on the medial aspect of the humerus or the ulna. We see the flexor carpi radialis, the ulnaris, and the palmaris longus. And again, when we're talking about extensors, these are all going to have their origin on the lateral surface of the humerus or even the radius. And these are going to be associated with carpi radialis longus brevis and the extensor carpi ulnaris. The primary muscles that move the phalanges, they're also involved in wrist action. They're very weak in wrist action, but we see the flexor superficialis, digitorum superficialis, which is going to move the interphalangeal joint. And then we see the flexor digitorum profundus, which is going to move the distal phalangeal joint. We also have a specific flexor pollicus longus. Anytime you see the word pollicus, it's associated, the Latin term for the word thumb. And thank you. That was a short video on wrist and hand structure and function.